In this section, we will discuss about developmental delay and behavioral problems in children. First, we will discuss about developmental delay in children. We will focus on causes of developmental delay, assessment of a child presenting with developmental delay, and features suggesting a developmental delay at specific ages. Developmental delay may occur due to a variety of causes. It may be due to a neurological developmental disorder, such as intellectual disability or autism spectrum disorder. It may also be due to an underlying medical condition, such as hearing impairment or neurological disorder. Environmental factors such as lack of stimulation and lack of social interactions may also contribute to developmental delay. In the assessment of developmental delay, firstly, look for any risk factors that could predispose to developmental delay. These include history of infections during pregnancy, such as toxoplasmosis, rubella, cytomegalovirus, herpes, birth complications such as premature delivery, birth asphyxia, extreme low birth weight, and postnatal complications such as neonatal seizures and infections. Next, a detailed developmental history should be taken, focusing on all domains of development, including gross motor, fine motor, speech and language, social and cognitive development. Finally, the child's independence in activities of daily living should be assessed. This includes assessing whether the child is able to do age-appropriate day-to-day activities such as dressing himself, washing himself, and other self-care and self-help activities. This slide shows the normal developmental milestones in children. In summary, with regard to gross motor development, by 6 to 8 weeks, a baby is usually able to lift their head to 45 degrees when in the prone position. By 6 to 8 months, babies are able to sit without support, and by 1 year, they are usually able to walk a few steps on their own. With regard to fine motor development, by 6 months, a baby should have developed a palm grasp, and by 10 months, they would have developed pincer grasp. Normally, babies would start scribbling between 16 to 18 months and would be able to draw a circle by 3 years, a square by 4 years, and a triangle by 5 years. Children are able to build a tower of 3 blocks by 18 months and a tower of 6 by 2 years. With regard to speech development, children start to say their first word usually by 10 months, and they are often able to use about 2 to 3 words by 1 year. By about 20 months, children start joining 2 words together to form short phrases, and by 2 years, they should be able to use 2-word phrases. Usually by 3 years, children talk in 3 to 4-word sentences. Babies start to smile responsively around 6 weeks of age and start pointing at objects around 9 months of age. They're usually able to wave bye-bye by 12 months, pretend to play, and symbolic play starts around 18 months. Their ability to engage in interactive play emerges around 3 years. Children may vary in the age they achieve their developmental milestones, and slight delays in development may be normal. However, there are certain ages at which children should acquire certain development milestones, and if these development milestones are met by a certain age, it indicates a definite delay. For example, if by the age of 2 years a child has difficulty in walking alone, is unable to follow simple commands, is not able to speak in 2-word phrases, or is not able to understand the use of everyday objects, this indicates a definite delay in development. If by 3 years a child is not able to climb stairs by himself, does not like playing with other children, does not engage in repetitive play, or cannot speak in 3-word sentences, this indicates a definitive delay. Similarly, if by 4 years a child is not capable of jumping up and down and is not able to talk clearly in a way that is easily understood by others, or is not able to identify similarities and differences between objects, this indicates a definitive delay in development. Again, by 5 years, if a child does not know their full name or birthday, does not identify colors, or has speech that is not easily understood, this clearly indicates a delay. By 6 years, if a child is not able to identify letters and numbers, cannot describe an incident or tell a simple story, does not have the concept of days and months, or cannot count to 20, this again shows that there is a definitive delay in their development. Now we will move on to autism spectrum disorder, which is a common neurodevelopmental disorder. Autism spectrum disorder affects about 1% of children worldwide. A study done in suburban area in Colombo in 2009 has shown 1 in 93 children to be affected with autism. It is characterized by difficulties in social communication, impairments in social interaction, and the presence of restrictive repetitive interests. Children with autism spectrum disorder may present in different ways. They commonly present with speech delay. However, some children may present with speech regression, which is loss of previously learned language, which usually occurs within the first 2 years. Some may present with abnormalities in speech, such as pronominal reversal, using you instead of me, echolalia, repeating the same word, jargon language, constantly speaking in a language that is not understandable, and neologism, making up new words for objects. Alternatively, the child may be able to speak but not use speech to communicate with others. They also present with a range of abnormalities in social interactions. They often have poor eye contact and other nonverbal communication, such as facial expressions, social smile, gestures, is also often impaired. Usually by 3 years, children like to play with other children. But children with autism are not interested in others and prefer playing on their own. They lack imaginative play and imitative play by the age of 3 years. They have difficulty making friends and have limited friendships. Children usually share their interests with others, but children with autism do not share their interests with others. Their ability to understand other people's feelings and facial expressions are also limited. In addition, they may not seek comfort when they are hurt. They may also present with restrictive, repetitive interests and behaviors. Children with autism may engage in repetitive movements such as rocking, hand flapping, rotating, or twirling the hand or fingers, fluttering fingers in front of the face, jumping, spinning, slapping self or an object or surface. They may engage in repetitive play such as lining up toys, or may insist on sameness and routine. For instance, eating the same food every day, insist on wearing the same colored clothes, and insisting on using the same route to go to school. They may get extremely distraught at small changes in their routines and have difficulties with transitions from one activity to another. Children with autism have highly restricted, fixated interests that are abnormal in intensity or focus. For instance, strong attachment to a preoccupation with unusual objects, playing the same game over and over again every day, turning a toy car upside down and rotating the wheels over and over again. They may also have hyper or hyposensitivity to sensory stimuli. There are some red flags that suggest the presence of autism at early stages. These include not babbling or cooing by 12 months, not pointing to objects or waving bye-bye by 12 months, not using single words by 16 months, or not speaking in simple two-word phrases by 2 years. Losing previously acquired speech or language skills at any age is also red flag for autism. Management of autism requires the input from a multidisciplinary team of professionals, including a pediatrician, a psychiatrist, speech therapist, occupational therapist, and social worker. Therefore, any child suspected to have autism should be referred to mental health services. As early interventions are proved to improve the prognosis of autism, it is important that the child is referred for services as soon as possible. Now we will move on to the next topic, which is behavioral problems in children. Behavioral problems in children may be due to a wide range of causes. Behavioral problems may occur as a part of neurodevelopment disorders such as intellectual disability, autism spectrum disorder, or attention deficit hyperactive disorder. It can also be due to behavioral disorders such as conduct disorder or oppositional defiant disorder. Emotional disorders such as depression, anxiety, or reaction to stress can also give rise to behavioral problems in children. It can also be a manifestation of attachment disorders. Behavioral problems may reflect an underlying environmental problem such as parenting problems or lack of opportunity to play and engage in age appropriate activities. We will first discuss about attention deficit hyperactivity disorder, commonly known as ADHD. ADHD is a neurodevelopmental disorder that affects about 5% of children worldwide. It is common among boys than in girls. There are three main features of ADHD. These include hyperactivity, inattention, and impulsivity. Hyperactivity may manifest as inability to sit still, fidgeting, and restlessness. Children with ADHD often walk around when they are supposed to be seated. They may act as if being driven by a motor. They talk excessively and are unable to play quietly. They climb, jump from heights, and engage in other risky behavior. Inattention often manifests as forgetfulness. These children often lose their belongings and forget to convey messages. They cannot concentrate on one task for long and often stop tasks halfway. They are easily distracted by external stimuli and dislike engaging in tasks that require sustained attention. Impulsivity may present as difficulty waiting for their turn. They may frequently interrupt others' conversations and have difficulty in controlling their anger. For ADHD to be diagnosed, symptoms must start before the child is 12 years. The symptoms must be present in more than one situation, and there should be functional impairment resulting from these symptoms. Diagnosis of ADHD should be done by a psychiatrist. There are pharmacological and non pharmacological management for ADHD. Management should be initiated by a psychiatrist. Therefore, if a child is suspected to have ADHD, they should be referred for assessment by a psychiatrist.